Yeah, so dyslipidemia in children is indeed a neglected topic. So in next 25 minutes or so, I chose to be very focused on discussing the pathophysiology, the normative ranges. I'll be discussing the common hereditary dyslipidemias. I'll be just touching upon briefly on the secondary dyslipidemias related to diabetes, and then the screening guidelines for dyslipidemia in children. So in very brief about the lipid metabolism, so all of us are aware of the exogenous pathway where the intestinal cells pour the chylomicrons that are generated in the intestinal cells into the lymph. Bypassing the liver, it goes in directly into the bloodstream. It releases some amount of fatty acids and goes on to chylomicron remnants, which are then taken up by the liver. The endogenous pathway is what begins from the liver. So the liver generates VLDL. That's a very, very large and very low density molecule secreted in the circulation, again releases a lot of free fatty acids and triglycerides to become intermediate density and ultimately the low density molecule, also called as the LDL. So this LDL is a relatively stable molecule. It stays in the circulation, and this is the molecule. If it is present in excess amounts, it interacts with the macrophages and causes the plaque formation. There is a LDL receptor in the peripheral tissues, including the liver, where the LDL is internalized and then it is metabolized by the LDL receptor and further intracellular mechanisms. And these peripheral tissues along with the liver would generate HDL. So HDL is a scavenging molecule which will pick up all the garbage, and it will deliver it back to the liver to burn it out. And also HDL will deliver these cholesterol remnants to adrenals and the ovaries and testes, also called as the steroidogenic organs. So what are the pathophysiological targets when we are talking about dyslipidemias? So there are two important targets that we must understand in the pathophysiology. One is in the exogenous pathway, where the chylomicron remnants are taken up by the liver using the remnant receptor. So if the remnant receptor is faulty, or there is some problem in the subcellular pathways of these receptors, some mutations, then you have piling up of the chylomicrons and thereby the triglycerides in the circulation, thus giving rise to hypertriglyceridemias. You have the second arm in the endogenous pathway, where the uptake of the LDL by the LDL receptors, and most often the LDL receptors, most abundantly they are present on the liver. So the liver does not take up the LDL, and they pile up in the circulation, giving rise to the atherosclerotic plaques. What are the reference ranges given for the children? Please remember the definition of metabolic syndrome that we heard a few talks ago. You might be remembering that the triglyceride value mentioned there is 150 and above, but the normative references, these references come from the NHLBI guidelines from the US. And the triglyceride less than 75 or less than 90 are the acceptable ranges, and any value above 100 or above 130 for triglycerides in children and adolescents are taken as abnormal. For LDL, the target is 110, and any value above 130 is considered as abnormal. And this 130 would be the threshold when you have elevated LDL along with some comorbidity like diabetes. How do we classify? You, all of us have gone through those types of familial dyslipidemias, but I have just cut it short very concisely. I have just divided it into primary and secondary dyslipidemias. So the important ones that a clinician should remember is hypercholesterolemia, that comes to us in the heterozygous form commonly, and very, very rarely as a homozygous form. um, Triglyceridemia is the common one, is the familial hyperchylomicronemia syndrome, and there is much more commoner. The garden variety dyslipidemia that we see is the familial combined dyslipidemia. What are the secondary causes of dyslipidemia in children? The common ones are diabetes, obesity, hypothyroid. PCOS is also one of the secondary conditions that can give rise to dyslipidemia, particularly. Drugs like steroids, OC pills, vitamin A, certain antipsychotics can also give rise to dyslipidemia. So the common primary dyslipidemias I have already elaborated: the familial hypercholesterolemia, the heterozygotes and the homozygotes. The frequency is there in front of your screens. Um, so the predominant mechanism or the mechanism of defect is decreased LDL clearance in hypercholesterolemia, the increased ApoB production in combined hypercholesterolemia, and decreased triglyceride uptake or the degradation in hypertriglyceridemia. It's very easy to remember. So what are the screening guidelines? What is to be screened, what is to be tested, when is to be tested, and how do we intervene? So this is the guideline that comes from the expert panel on integrated guidelines for cardiovascular health and risk reduction in children. So this is coming from the Pediatrics 2011 guideline. So where there is no universal screening recommendations for children below 2 years, be it selective or universal. Children between 2 years to 8 years, if you have risk factors like diabetes, hypertension, if you are exposed to secondhand smoke, there is also mention of primary smoking, but we don't expect children to smoke, so I have removed that. Chronic kidney disease, any cardiac transplants, Kawasaki, whether current or past, any chronic inflammatory diseases, rheumatological diseases, along with family history of atherosclerotic cardiovascular disease in either of the parents or the grandparents. So if you have this setting of high risk along with the family history, then you would be screening the child at least once between 2 to 8 years. If there is no such risk factor in the family and also in the child, then there is no recommendation for universal screening between 2 to 8 years. Once the child becomes 9 to 11 years, so roughly to remember, 10-year-olds need their lipid profile to be done, and this is the universal recommendation. So all children on their 10th birthday have to be screened for lipid profile. Between years 12 to 16, also the early pubertal age groups, typically in boys between 12 to 16, and in girls during their early puberty, so somewhere between 10 to 12, we should not be doing lipid profiles. And even if we do the lipid profile for certain conditions, we should be very careful, because there is a physiological dip in the total cholesterol and the LDL levels, because the puberty is a condition where you see lower cholesterols typically during the early pubertal age group. On the 18th birthday, again, there is a recommendation for universal screening. So to summarize, on the 10th birthday and on the 18th birthday, every child needs to be screened. This is the universal screening policy. And otherwise, you have the targeted screening if you have the risk factors. In type 1 diabetic children, when do we screen? So earlier the recommendation was on the 10th birthday, but now we have on the 11th birthday or at the onset if the child is already above 11. If the lipid profile comes normal, then you will repeat it every 5 yearly. If there is a family history positive, then even before 11 years of age, you would be screening it. Fasting is not really required as a screening protocol. Only if your fasting triglyceride comes higher or the LDL level comes higher, then you may repeat it in a fasting state. But as a general screening protocol, fasting sample is not required. If we had time, we would have discussed the difference between direct and calculated LDL. But if your triglycerides and VLDLs are normal, then you really don't have to go for the direct LDL. Only if you have problems in your TGs and the VLDLs, that is the time you have to go for direct LDL estimation. So start on statins only if there is failed lifestyle management in type 1 diabetes, along with a good control of sugar. If you can't bring the LDL concentrations below 130, then for your teenage or the adolescent type 1s, you would be starting on statins. Lifestyle modifications, if you have elevated LDL levels or triglyceride levels, the lifestyle modification remains same for your triglyceridemias or your obesity. So physical activity more than 60 minutes or at least 60 minutes per day. The screen time recommendation comes from the US AAP, again 2 hours of screen time, but this does not hold true for Indians because we have a lot of school time and the tuition time. Attainment of ideal body weight. Of course, treat and prevent obesity and optimize blood pressure. These are the lifestyle modifications that one should be trying before starting the child on statins for at least 6 months. What are the dietary interventions for children with dyslipidemia? So this is called as Child 1 diet, also called as the Cardiovascular Health Integrated Lifestyle Diet 1. So we restrict the saturated fat intake to less than 10% of the daily intake, reduce the total cholesterol consumption to less than 30 milligrams per day, and reduce these sugar sweetened beverages and improve their fiber content. So you would be getting a deja vu from your obesity panel. So similar guidelines are also established for obesity, but these are more stricter in terms of your saturated fat content and the choice of fat. Child 2 is more stricter in intensification of dietary fat and increasing the MUFA and PUFA percentages. In cases of triglyceridemia, before you consider adding any drugs, you want to add the plant sterols. You reduce the dairy consumption, the meat consumption, and put them on plant-based oil sources. So plant sterols, they compete with the cholesterol for the absorption in the small intestine. Adding psyllium fiber also reduces the absorption, and adding omega-3 fatty acids has also been shown to help in triglyceridemia. So these are the MUFA and PUFA sources that one needs to encourage in a child's diet, and especially if it is culturally approved and acceptable, then consumption of fatty fish is considered very, very helpful for children with triglyceridemia. Hypercholesterolemia, when do we treat? So these are again guidelines from 2014 JCEM guidelines. So if the LDL levels are above 190 after treating the underlying conditions like diabetes or any other conditions, you will treat the child with 6 months of lifestyle modification, and if it does not help in the reduction of the LDL, one would be starting them on statins, boys after Tanner stage 2 and girls only post menarche. Children having their LDLs between 160 to 190, you would give the lifestyle modification until 12 months and then reassess. But if you have one risk factor that is high risk or two moderate risk factors, then you would be treating again with the same guideline. LDL values between 130 to 160, you need to have two high risk factors or one high risk and two moderate risk factors in order to consider treatment with statins, but of course after 6 months of lifestyle modification. And what are those high risk conditions and high risk factors? Some of them we have already discussed, like diabetes in children, renal disease or renal transplant, heart transplant, Kawasaki disease, whether current or past. These are the risk factors. Any chronic inflammatory diseases comes under the moderate risks. And in the high risk factors also comes hypertension requiring medication and BMI above 97 percentile. So these are the high risk children who you would be treating above 130 milligrams of LDL concentration. And they also need to have the family history as a mandatory factor, and the guidelines are in front of your screens. I'll be quickly going through one of my mutation proven cases of hypercholesterolemia. So this was a child that came to me at 2 years of age with gradually increasing these fleshy lesions over the skin folds, non-tender, and he was born out of first degree of consanguineous union, and these lesions kept on increasing over a period of time. So we did his lipid profile to find that cholesterol was more than 1000 with an LDL of 952. So this was indeed very, very elevated LDL, giving rise to those xanthomas. So we did his parents' lipid profile, and the parents were also had a moderately elevated total as well as total cholesterol as well as the LDL. So here we concluded that both the father and mother have hypercholesterolemia, and the child was born with a consanguineous union, so probably the child also has the severe defect. So we went ahead and treated this child with statins after initial lifestyle management, which clearly failed. And at At 4 years of age, we started treating this child, and look at this response of LDL and total cholesterol. We clearly could not achieve the target LDL levels. So we kept on increasing the doses of statins from starting from 10 milligrams to 20 to 60 to 80. In the published literature, I could get the highest dose of statins to be 80 milligrams per day. And then we added a molecule that is called ezetimibe, which acts on the receptor where the cholesterol and lipids are absorbed through the intestine. So it reduces the intestinal absorption. And in the last visit, we have added aspirin because the child just fails to respond to all these drugs, and he is very high risk for cardiovascular events. We went ahead and did his mutation screening. So these are the lesions that have been growing over last 4 to 5 years, and although the parents are very concerned about the skin lesions, we as the caretakers are more worried about the cardiovascular complications that we are expecting in next coming 5 to 10 years. So this child indeed showed a homozygous mutation in the LDL receptor that is present in the liver and the peripheral tissues, and he indeed turned out to be the homozygous variety of familial hypercholesterolemia syndrome. Please remember, the inheritance is autosomal dominant. So if you have one copy that is faulty, you get the heterozygous variety of hypercholesterolemia that is present in the parents. Unfortunately, both the parents are carrying the same gene, so the child has the most severe form, also called as the homozygous variety of the familial hypercholesterolemia. We have one more child coming to us with the same features, but the presentation was much earlier, starting from the infancy, and he also turned out to be positive for the same gene, but at a different location. So these are the genes responsible for hypercholesterolemia. Either there is a defect in the LDL receptor or the subreceptor levels. And these are some genes that are responsible for other parts of other mimics of hypercholesterolemia, like cytosterolemia, which is indeed a benign condition. So this one is a lethal condition. We must treat this because the homozygous variety, if we don't treat them adequately, they are likely to have their cardiovascular event before the 20th birthday. So we have started the parents also on statins, and the child is being treated on statins with ezetimibe. This is a very small cohort of my own data from my clinic over the last 6 years. So I have been taking care of these 4 or 5 patients with hypercholesterolemia and a couple of them with hypertriglyceridemia. So statins in children, Dr. Khadgawat sir had raised a valid point that are they safe? So these inhibit the synthesis of cholesterol in the liver, thereby reducing the total cholesterol, the LDL, and there is a modest rise in HDL concentrations. The side effects are there, like elevated liver enzymes and muscle aches and pains. They cause, in some, they cause rhabdomyolysis. But if you really look at the literature, are they successful in reducing the LDL concentrations? So the percentages of the LDL fall are anywhere between 20 to 40%. And rosuvastatin, this particular study I could find where they have treated the homozygous variety children with 80 milligrams and they could barely achieve 21% of fall. So clearly homozygous ones are very difficult to treat, but the heterozygotes and the non-familial in such conditions. So here is a paper from 2011 where 185 children were treated with hypercholesterolemia and they had 25% reduction in LDL and absolutely no effect on their growth and puberty. 13% had mild side effects and 4 had minor muscle aches. And this is Cochrane database review from the last year. It quotes that few or no safety issues were identified, and statin treatment in shorter durations are safe, but we have to have long-term safety data that is still unknown. This is one study, SafeHeart, coming from the familial hypercholesterolemia syndromes, the heterozygotes. Very difficult to treat even the heterozygotes. Only 12% could achieve the target of LDL of 100 to 130. Children with familial hypercholesterolemia typically have a plateau happening after first 6 months of treatment, and this plateau remains over next 3 years. So we have to escalate the treatment, and at early stage one has to think about going ahead with liver transplant in the homozygous variety. Ezetimibe is an antibody that reduces the intestinal absorption, and there is only one study published in 2013 of reduction of 27% of LDL when 10% of ezetimibe was added in children between 6 to 12 years of heterozygous familial hypercholesterolemia. So this is a pictorial presentation of how the statins would help in such conditions. So they will bring from an LDL from 500 to 380, but you need to add apheresis or the newer molecules that act on the PCSK9 gene to achieve better control in heterozygotes. One more molecule is alirocumab, which prevents the degradation of the LDL receptor, thereby makes the LDL receptor recycled and available again to take up the LDL, thereby reducing 35% of the LDL concentration when it is given. So there is only one published study of alirocumab in the familial hypercholesterolemia in children, and it was a small cohort of 42 children, and they could achieve 45% reduction in the LDL safely without any major side effects. Hypertriglyceridemia, not very common, but it is generally accidentally detected with lipemic serum, or it is detected during the screening for obesity or PCOS. The severe ones need treatment, and the milder ones need only lifestyle modification and some dietary modifications. So these are the lifestyle changes. So in addition to what we have already seen, addition of fish oil, addition of fibrates and fibers to the diet helps. If you have TG levels above 500, if the TG levels are above 1000, then one has to consider insulin. Typically, if the patient also has diabetes, IV insulin or plasmapheresis is also recommended. So this brings me to the last part of my presentation, where I'm summarizing my talk in just 7 points for you. Universal lipid profile screening for all children on their 10th birthday and 18th birthday is recommended. Targeted screening for children with risk factors or risk conditions, and we have seen what are those risk conditions already. Lifestyle modification for 6 to 12 months for non-familial dyslipidemias needs to be considered before starting statins. Statins are generally well tolerated, and they are recommended if the LDLs are above 190 despite 6 months of lifestyle modification, or if they are above 130 or 160 depending on 2 or 1 major risk factors being present. Diabetic children above 11 years with an LDL of 130 need statin treatment, and this comes from the ISPAD 2018 guideline. Often we do not get the lipid profiles of our type 1 children because they do not come to us in a fasting state. So the current guideline ISPAD 2018 mentions that fasting is indeed not required. You can get a random LDL as well done. If the lifestyle doesn't help, then you must treat these children with statins. Statins are well tolerated, and they are approved above children above 7 years of age. And the familial hypercholesterolemias, they are very difficult to treat, and the homozygotes are almost impossible to achieve the targets, and they need the maximum dosing of lipid lowering agents along with the NP1C1 inhibitors like ezetimibe or the PCSK9 inhibitors like alirocumab. With this, I conclude my talk, and since Dr. Khadgawat sir sees more hyperlipidemias than me, I'll invite his comments also and his insights also.
Yeah, thank you, Tushar. Really wonderful talk. Dr. Tushar has initially started with description of what cutoffs we use in pediatric age group. What are these cutoffs level, how we can define these dyslipidemias, and then how to investigate for these all secondary causes, which is very important in these cases. Whenever you see a case with dyslipidemia, first think of secondary cause and then take a strong family history, complete family history of atherosclerotic vascular disease or dyslipidemia in children, and then decide whether to treat or not treat. And I was really impressed with one of the portion of the presentation is he has devoted much more time on the diet, which is lifestyle modification is the first step of management of dyslipidemia in this age group. And many of the times we first go for lifestyle modification. We try to see not definitely in familial hypercholesterolemia, whether it's heterozygous or homozygous, they are less likely to respond to dietary or physical activity modification. But for most other cases, these are the most important steps. And then Dr. Tushar has discussed the role of the drugs, especially our cornerstone of treatment is statins. We all know we use statins. Statins have been used in pediatric age group, and they discussed that these are absolutely fine. There is no major concern with the use of statins. Other drugs are still in the phase of development, like PCSK9 inhibitors are not wide experiences available. They are approved for use in the familial hypercholesterolemia in adults, yet to be approved in pediatric age group. We do not see much difference, but still these drugs safety and efficacy has to be proven in pediatric age group. So this well concluded and well summarized talk, and I think everybody should have been benefited with the all detailed description of management of dyslipidemia, which is a common problem. Most of the time we neglect, we do not investigate our children for dyslipidemias. That's why we do not see many of these cases. Especially those cases where we see secondary factors or those who are obese or having other risk factors should be investigated. So if time permits, we can go for a couple of few questions. Dr. Rakesh, can we go for a few questions?
Yes, sir. We have 3 minutes maybe. We can cover 2 questions. Yeah.
We'll conclude in 3 minutes. Okay, Dr. Tushar. So Ashu wants to know that omega-3 fatty acids in hypertriglyceridemia, which commercial formulations are available and in what dosage, especially in terms of your personal experience in using these preparations for dyslipidemia.
Yeah, so I don't have much experience on managing the hypertriglyceridemias, but there are capsules of omega-3 available, typically known as the cod liver oil preparations. Offhand, I don't remember the dose, but I would like to look up and answer this question.
Sure. Dr. Ashima wants to know that any experience with side effects of high dose of statin, especially I was a little bit worried the dose you have used of 120 milligram is really worrisome. And my personal experience is if you see a homozygous hypercholesterolemia, whatever dose of statin you use, you will hardly able to make any difference. Even you were lucky that you got 20% decrease. We haven't seen more than 10% or 15% decrease. But again, depends upon the dietary restrictions. So have you experienced side effects of high dose of statin?
So I have 5 patients with hypercholesterolemia. 2 of them are mutation proven. Only one of them had mild transaminitis of SGPT going up to 60, 65. But I mean, not really worrisome. Muscle aches, it is often mentioned that rhabdomyolysis and muscle pains, proximal myopathy is mentioned in the literature, also the FDA warning. But most of the papers that I could go through mention that it is tolerated very well. So it's a very rare.
Go ahead.
So seeing rhabdomyolysis or muscle aches is rare in pediatric age group.
Okay. So Dr. Santosh from Karnataka Institute of Endocrine Research wanted to know, like you have discussed universal screening. But it's little bit debatable, especially seeing our health infrastructure. So he wants to know that what's your comment? US people have suggested that universal screening should be done. Do we really recommend in our own country? Because in adult population, we have clear data that we have a different dyslipidemic profile in comparison to the Caucasians. I'm sure there must be some Indian data also where dyslipidemia has been described. So,
So
do you
I
really
fully
think that we go for universal screening?
I don't agree with that recommendation, because first of all, it comes from US.
Yeah, yeah.
So we have to have our own data coming from the pediatric age group of prevalence. And of course, we have bigger health problems to tackle to than detecting hyperlipidemia as a national program. But of course, we should be vigilant, and we should be doing a targeted screening for all obese children, all children with a family history of early cardiovascular event, all children with diabetes, all children with PCOD, or all children with any autoimmune conditions or chronic inflammatory diseases. So targeted screening, I fully agree that we must do. Universal screening, we need to have our own set of data and our own experience before we can recommend for Indian population.
Yeah, Tushar, I would like to just share that couple of years back, we did one study around 1,700 boys and 1,700 girls, and this was published in Clinical Biochemistry.
Correct.
And we have collected fasting lipid profile, ruled hypothyroidism, diabetes, and this was published. And we have seen that our profile of dyslipidemia is entirely different from what we see in Caucasian population. Our major concern was high triglyceride and low HDL level. LDL, high LDL in our pediatric age group is hardly of any concern. Maybe I don't remember exactly what was the percentage, but major concern was high triglycerides and low HDL. So it may be possible that after some time we may look upon our own data and find out if, like guidelines you have discussed, is giving 130 triglycerides. Triglyceride 130 in our population, especially in pediatric age group, is quite common, and treating more than 130 may be cumbersome for our safety has not been proven. So we may look upon our own data, and a couple of other papers have also been published from the Indian population, where people have tried to divide the dyslipidemia in general Indian school going age children. Last data is also available. So sure, we can look up upon these data and find out our experience also. Dr. Pankaj Patwari wants to know that, Rakesh, last question. I'm sorry, just last question. What other drugs can be used in a child who is 8 years old? Ezetimibe, bile acid sequestrant, or bempedoic acid? Are these drugs? Any experience? You might have reviewed literature while preparing for your lecture. So what's your comment on that?
People have added bile acid sequestrants in addition to ezetimibe, but I don't have any personal experience of that.
Okay, okay. Thank you, Tushar. It's a wonderful lecture, and especially your dietary portion was very extensive and very useful. Before shifting to all these drugs, we should go for strict dietary control in dyslipidemic children. That's the key message we can derive from your lecture. And thank you very much for your wonderful lecture. Over to Dr. Rakesh.
Thank you.
Thank you very much, sir. Thank you, Dr. Rajesh, for your practical inputs. And we would have listened more to you, but for the sake